Okay, let's unpack this. Picture an emergency department.
Yeah.
It often feels like just a whirlwind, right?
Oh,
A
absolutely.
chaotic, uncertain environment where absolutely anything can walk through the doors. But beneath that fast-paced exterior is a highly systematic and critical approach to saving lives. It's sort of a dance between urgency and precision.
Yeah, and what's truly fascinating is that while the ED looks chaotic, it's actually governed by a pretty profound understanding of specific nursing concepts and, patient problem-solving approaches.
Mhm.
The core skill of an ED nurse isn't just reacting, it's being prepared for anything, recognizing life-threatening illness or injury, and starting interventions, sometimes, like you said, even before a definitive medical diagnosis is even made. It's about buying precious time.
Absolutely. And that's really our mission today. We're doing a deep dive into the essentials of emergency and disaster nursing, pulling key insights directly from Lewis's medical surgical nursing. This isn't just about memorizing a list of facts. It's about understanding the why behind the what. So you, as future nursing professionals, can navigate these really high-stakes situations with both confidence and competence. Get ready to connect the dots, have some aha moments that'll be invaluable for your studies and your future practice.
We'll guide you step by step through this whole theme of emergency preparedness. We'll cover everything from, initial patient assessment and the critical art of triage to managing environmental emergencies like heat stroke or frostbite.
Oh, yeah.
And even those specific challenges like bites, stings, toxic exposures, and even thinking about large-scale disaster responses. We'll always try to connect the pathophysiology to the practical nursing interventions, helping you see how to apply this knowledge in real-world acute and chronic care settings.
Perfect. So let's start at the beginning. Imagine the doors fly open. Suddenly you have multiple patients arriving, each with a different problem. How on earth do you decide who to run to first? That's the life-saving puzzle of triage, and it's honestly one of the most important assessment skills you'll develop.
You've hit on the core challenge right there. Triage is that.
ESI-1 means immediate life-saving intervention is needed right now, like cardiac arrest, an intubated trauma patient, someone in severe respiratory distress.
Yeah.
Zero time to spare.
Correct. They cannot wait at all.
And ESI-2 is still a high-risk patient who cannot wait long to be seen, but maybe doesn't need that immediate life-saving intervention this exact second. They're still seriously ill, though.
Precisely. Think maybe chest pain that sounds like ischemia, or perhaps an immunocompromised patient with a fever. Very high risk, needs attention quickly, but maybe not coding in front of you.
Okay. Then you have ESI-3, 4, and 5. These are the patients who can wait a bit longer, and the difference between them comes down to resources.
Exactly. It's about the number of resources you anticipate they'll need. And resources mean things like labs, maybe an ECG, IV fluids, IV meds, things like a simple tetanus shot or a basic wound dressing. Those usually don't count as a resource in this system.
Gotcha. And there's a key point about ESI-3, right? About vitals.
Yes, absolutely. An ESI-3 patient must have normal vital signs. If their vitals are abnormal, even if they seem okay otherwise, they often get bumped up to ESI-2 because instability signals higher risk.
Okay, that's a critical distinction. Can you give us a quick example?
Sure. Let's take that case from the chapter. A 24-year-old man comes in, says he thinks he has food poisoning. He's been vomiting all night, has diarrhea, rates his abdominal cramping a 6 out of 10.
Okay.
He denies fever or chills, and his vital signs are actually stable, normal temp, heart rate 94, breathing 16, BP 121/74. Based on the ESI algorithm, he'd likely be an ESI-3.
Right, because he needs resources, labs, maybe fluids, but he's not in severe distress. And crucially, those vitals are stable.
Exactly.
Okay, so once triage has happened, the primary survey kicks in. This is that rapid, systematic approach to find and fix the immediate life-threatening problems. We often use the mnemonic A, B, C, D, E, F, F, G.
Yes, but before we even hit A, there's a really critical point. If you walk in and see uncontrolled external hemorrhage, we're talking bright red, pumping blood, the usual ABC changes. It becomes CABC. That first C stands for catastrophic hemorrhage. You have to control that bleeding first, usually with direct, firm pressure, because, well, you can't circulate blood if it's all leaving the body.
Right. Stop the leak first. Makes total sense. Okay, so keeping CABC in mind, let's go through the standard sequence. A is for
A is alertness and airway. Two parts there.
alertness and airway.
Okay.
Nearly all immediate trauma deaths happen because of an airway obstruction. It could be saliva, blood, vomit, even just the tongue falling back.
Wow.
So first, you check alertness using that simple AVPU mnemonic. Alert, responsive to voice, responsive to pain, or unresponsive. Then you look and listen for any signs of airway compromise, difficulty breathing, gasping, inability to speak.
And interventions.
They range from least to most invasive. You might start with a jaw thrust maneuver, remembering always to protect the cervical spine if there's any suspicion of injury.
Right. No head tilt chin lift in trauma. Correct.
Mhm.
Then maybe suctioning, inserting an oropharyngeal or nasopharyngeal airway. And if needed, it could escalate to rapid sequence intubation or even an emergency surgical airway like a cricothyroidotomy.
Okay, so A is clear. B is breathing.
Right. Just because the airway is open doesn't mean the patient is breathing effectively. Things like fractured ribs, a pneumothorax, a collapsed lung can seriously impair ventilation.
So you're assessing.
You're looking at chest rise and fall. Is it symmetrical? Are they using accessory muscles to breathe? You listen for breath sounds. Are they present? Equal, clear. And remember, every critically ill patient needs supplemental oxygen, usually starting with high flow, 100% via a non-rebreather mask.
And if that's not enough?
You might need to assist ventilation with a bag valve mask or BVM. In cases like a tension pneumothorax where air is trapped and collapsing the lung and heart, you might need to do an emergency needle decompression or, again, intubation for severe respiratory distress.
Okay, ABC is circulation and hemorrhage control if we didn't do it first.
Exactly. C is circulation and control of hemorrhage, you're asking. Does the patient have an effective circulatory system? Is the heart beating? Are the blood vessels intact? Is there enough blood volume? Uncontrolled bleeding is the major cause of shock and trauma.
Assessment.
Checks central pulses, first carotid or femoral. They're more reliable than peripheral ones in shock. Assess the skin. What's the color?
Yeah.
Temperature. Is it moist? Delayed capillary refill longer than 3 seconds is a classic sign of shock, though remember, cold environments can slow it down too. Altered mental status is also a big red flag for poor circulation to the brain.
Priorities here.
If there's no pulse, start CPR immediately. Stop any ongoing bleeding with direct pressure. And critically, establish IV access, usually 2 large-bore IVs like 14 or 16 gauge, in the anacubital fossa if possible.
Watch the page.
For rapid, aggressive fluid resuscitation, we usually start with isotonic crystalloids like normal saline or lactated ringers. In really life-threatening hemorrhage, if you don't have time to cross-match blood, you might give O-negative blood, the universal donor type.
Got it. A, B, C, D is disability.
Disability, yes. This is a brief neurologic assessment. We use the Glasgow Coma Scale, the GCS, for a standardized score. It helps us communicate the patient's level of consciousness consistently, though remember, it's not accurate for intubated patients or those who can't speak.
And pupils.
Absolutely. Check pupil size, shape, equality, and how they react to light. Changes here can indicate increasing intracranial pressure.
Okay. E is exposure and environmental control.
Right. E1 is exposure. You need to remove all clothing to perform a thorough physical assessment. You can't find injuries you can't see, but be careful. Try not to cut through potential forensic evidence like bullet holes in clothing.
Oh, good point. And what about impaled objects?
Never remove impaled objects in the ED. Stabilize them in place. They need to be removed in a controlled environment, usually the operating room, where bleeding can be managed immediately.
Okay. And E2, environmental control.
Once the patient is exposed, they can lose heat very quickly, especially trauma patients who might be in shock or receiving room temperature fluids. So, prevent hypothermia. Use warming blankets, overhead warmers, warm 5E fluids. But also, maintain patient privacy as much as possible.
Right. F comes next, full set of vitals and family presence.
Yep. F1 is getting a complete set of vital signs. Temperature, pulse, respirations, blood pressure, oxygen saturation, and pain assessment. If you suspect chest trauma or the initial BP is abnormal, get bilateral blood pressures in both arms, as a significant difference could indicate aortic injury.
And F2, family presence.
This is important. Research actually supports allowing family members to be present during resuscitation efforts if they wish to be.
Really?
Yes. If a caregiver is present, it's good practice to assign a specific team member to stay with them, explain what's happening in simple terms, answer questions, and provide support. It can be comforting for the patient and helps the family understand the situation better, reducing anxiety.
That's great to know. Okay, last one. G, get monitoring devices and give comfort.
Correct. G1 is get monitoring devices. This is where we apply all the adjuncts. There's a useful mnemonic here, LMNOP.
LNOP. Okay, what's that stand for?
L is for labs. Get blood work drawn type and cross-match for potential transfusion. CBC, a comprehensive metabolic panel, maybe toxicology screens, arterial blood gases, ABGs. cardiac biomarkers if chest pain is involved, and always a pregnancy test on women of childbearing age.
Okay. L is labs.
M is monitor. Connect the patient to a continuous ECG monitor to watch their heart rate and rhythm. N is nasogastric tube. Consider an NG tube to decompress the stomach, which can reduce the risk of aspiration. However, if there's significant facial or head trauma, you'd use an orogastric tube placed through the mouth to avoid accidentally inserting it into the brain through a skull fracture.
Yikes. Okay. Oh.
O is oxygenation and ventilation assessment. Continuously monitor their oxygen saturation with pulse oximetry, SpO2, and ideally end-tidal CO2 with capnography, EtCO2, especially if they're intubated or ventilation is a concern. Capnography gives real-time feedback on ventilation effectiveness.
And finally, P.
P is pain assessment and management. Pain is often undertreated in emergencies. Assess pain levels frequently using an appropriate scale. Implement both pharmacologic, like IV opioids, and non-pharmacologic strategies early on. Treat pain proactively.
Wow, the primary survey is incredibly thorough, but has to happen fast.
It does. It's all about identifying and managing those immediate life threats systematically.
So once those primary survey issues are addressed and life-saving interventions are underway, we move to the secondary survey.
Correct. The secondary survey is a more detailed, systematic process designed to identify all other injuries. It's especially helpful if the patient's history is limited or confusing, maybe they're unconscious or intoxicated.
This starts with H.
Yes, H history and head-to-toe assessment. First, get the history. If the patient can't speak, talk to caregivers, paramedics, anyone who might have information.
Are there mnemonics for history too?
There are. For the report from pre-hospital providers like EMTs or paramedics, the MISS mnemonic is helpful. Mechanism of injury, injuries found or suspected, signs and symptoms field, and treatment given before arrival.
Missed. Okay. And for the patient's own history.
We use sample, symptoms associated with the injury or illness, allergies, don't forget drug and food allergies, and ask about tetanus status. Medication history, prescription, over-the-counter, herbal, past health history, including surgeries and hospitalizations, last meal or oral intake, important if surgery might be needed, and events or environmental factors leading up to the illness or injury.
Sample. Got it. Then the head-to-toe part.
This is a comprehensive physical exam. You inspect the head, neck, face, look for things like battle sign, bruising behind the ear, or raccoon eyes, periorbital bruising. Both can indicate skull-base fractures. Check for clear drainage from the nose or ear. It could be cerebrospinal fluid. Don't block it, just collect it. Inspect the chest again for movement. Palpate for tenderness or crepitus. Listen to heart and lung sounds again. Get an ECG and chest x-ray if indicated. For the abdomen, besides palpation and auscultation, a fast exam-focused abdominal sonography for trauma is often done bedside. It's an ultrasound looking for free fluid, usually blood, in the peritoneal space.
Quick way to check for internal bleeding.
Exactly. Though it doesn't see bleeding in the retroperitoneal space well, so a CT scan might still be needed. Gently palpate the pelvis for stability, but never rock the pelvis if you suspect a fracture. You could worsen bleeding.
Right. And extremities.
Assess all extremities for deformities, bruising, swelling. Check range of motion if possible. Critically assess for signs of compartment syndrome, severe pain, pallor, pulselessness, paresthesia, paralysis. And always, always check pulses before and after splinting or moving an injured limb. A pulseless extremity is a time-critical emergency requiring immediate intervention.
Okay, that's a lot in H. What's next?
I inspect posterior surfaces. This is easy to miss but crucial. You need to log roll the patient, always maintaining cervical spine immobilization with team members to visualize and palpate their entire back, looking for wounds, deformities, or tenderness.
Log roll as a team. Got it. And J.
J. Just keep reevaluating. Emergency care isn't static. The patient's condition can change rapidly. Ongoing monitoring is essential. We use another mnemonic here, VIPP. Vital signs, injuries assessed, and interventions performed. Ongoing assessment of the primary survey, ABCs, and pain level and management.
VIPP. Keep reassessing.
Constantly. Airway and breathing especially need frequent reassessment. And don't forget, tetanus prophylaxis, give it based on the patient's vaccination history and the type of wound.
Okay, that covers the core surveys. What about some special situations the ED handles? Like cardiac arrest?
Absolutely. For patients who have an out-of-hospital cardiac arrest, usually not related to trauma, and who achieve ROSC return of spontaneous circulation, a key intervention now is targeted temperature management, TTM.
TTM, therapeutic hypothermia.
Exactly, sometimes called therapeutic hypothermia. This involves actively cooling the patient's core body temperature down to a specific range, usually between 32 to 36 degrees Celsius or 89.6 to 96.8 Fahrenheit for at least 24 hours.
Why do that?
It's primarily for neuroprotection. It's been shown to significantly decrease mortality and improve neurologic outcomes in patients who remain comatose after ROSC. Methods can include ice packs, cooling blankets or pads, or even internal methods like endovascular cooling catheters.
Fascinating. Now, a difficult topic.
Yeah.
Sometimes, despite everything, death occurs in the ED.
It does, and it's often sudden, unexpected, and deeply shocking for families.
What's the nurse's role then?
Your role in providing comfort and support is absolutely crucial here. Offer a private space for the family to grieve and say their goodbyes if possible. Arrange for support services like a chaplain or social worker. Help gather the patient's belongings. And you need to be aware of the procedures for potential organ donation.
Organ donation.
Yes. Some patients who die in the ED may be candidates for organ or tissue donation. Approaching the family about this requires immense sensitivity and specialized training, usually done by personnel from the organ procurement organization, but it can sometimes provide a sense of meaning or purpose for the grieving family.
That's important to remember. What about our older adult patients? You mentioned they have unique vulnerabilities.
Yes, gerontologic considerations are vital. Patients over 60 make up a significant portion of ED visits. They're at higher risk for injury, particularly falls, due to age-related physiological changes, things like decreased vision, hearing, muscle mass, slower reflexes, decreased body fat, lower energy reserves, and a slower metabolic rate.
So they're just more fragile.
In some ways, yes. And critically, it's important to fully investigate any complaint they have. Older adults sometimes minimize or dismiss potentially serious symptoms, thinking that's just part of getting old. You have to dig deeper. If an older person falls, always consider, was the fall caused by an underlying medical event, like a stroke, a heart rhythm problem, or maybe low blood sugar? Or did the fall itself cause a new injury? Maybe a hip fracture, or even a subtle head injury causing confusion. You need to look beyond the obvious presenting problem.
That's a great point. Okay, let's shift gears a bit to environmental emergencies. With people outdoors more, these seem increasingly common. Let's start with heat.
Right. Heat stress happens when the body's cooling systems, primarily sweating and vasodilation, where blood vessels widen to release heat, just can't keep up with high outside temperatures, especially with high humidity.
And some people are more at risk.
Definitely. Risk factors are varied things like alcohol consumption, age extremes. Infants and older adults are less efficient at regulating temperature. Dehydration, strenuous physical exertion, certain chronic illnesses like heart disease, and even some medications like diuretics or certain psychiatric meds can interfere with heat regulation.
Okay, so it progresses,
Yeah.
right? From cramps to exhaustion to the really bad one, heat stroke.
Exactly.
Tell us about heat cramps first.
Heat cramps are usually severe, brief muscle cramps, often in the large muscles you've been using heavily, like calves or thighs. They might come with nausea, a fast heart rate, looking pale, and lots of sweating. The good news is they usually resolve pretty quickly with rest, moving to a cooler place and replacing fluids and sodium, maybe Gatorade, or even IV fluids if needed. But you should avoid strenuous activity for at least 12 hours after.
Okay, then heat exhaustion.
Heat exhaustion is more serious. It's caused by prolonged exposure to heat, leading to significant dehydration and electrolyte imbalances. Symptoms include fatigue, nausea, maybe vomiting, extreme thirst, feeling faint or dizzy, low blood pressure, rapid pulse, and usually a mild fever somewhere between 99.6 and maybe up to 105.8 Fahrenheit or 37.5 to 41 Celsius. Crucially, they are still sweating profusely.
Still sweating, that's key. How do you treat it?
Treatment involves getting them out of the heat immediately, starting oral and IV fluid replacement to correct dehydration, and using cooling measures like placing cool, wet cloths or sheets on them, maybe using a fan. It's about replacing fluids and actively cooling them down.
And then the worst one, heat stroke.
Heat stroke is a true medical emergency. This represents a catastrophic failure of the body's thermoregulatory center in the brain, the hypothalamus. The key difference here is that the sweat glands stop functioning.
They stop sweating.
Yes. The body loses its main way to cool down. Core body temperature rises rapidly and dangerously high, often over 105.8 degrees or 41 degrees C. This extreme heat can cause cerebral edema, brain hemorrhage, seizures, coma, and multiple organ failure. The prognosis is directly related to how high the temperature got and for how long.
So immediate interventions.
Absolutely critical. Start with the ABCs. Then, rapid and aggressive temperature reduction is the priority. The most effective method is often cold water immersion, if possible. If not, spray the patient with cool water while directing a fan at them, place moist sheets over them, apply ice packs to major pulse points like the groin and axilla, give 100% oxygen, monitor their ECG continuously, manage electrolytes.
What about shivering? Doesn't cooling make you shiver?
It can, and you must control shivering, usually with medications like benzodiazepines, because shivering actually generates more heat, counteracting your cooling efforts. You also need to monitor closely for complications like rhabdomyolysis muscle breakdown, which can lead to acute kidney injury.
Wow. And discharge teaching is key here.
Very important. Emphasize proper hydration, especially during hot weather or exercise, wearing appropriate light-colored, loose-fitting clothing, and avoiding strenuous activity during the hottest parts of the day.
Okay, let's flip to the other extreme. Cold-related emergencies.
Right. Just as heat can overwhelm the body, so can extreme cold. Cold injuries can be localized, affecting specific body parts like fingers or toes, that's frostbite. Or they can be systemic, affecting the whole body, that's hypothermia.
What makes someone more susceptible?
Similar factors to heat, actually. Age extremes, duration of exposure, wet clothing, wind chill, inadequate clothing, certain medical conditions that impair circulation or sensation, alcohol use, which causes vasodilation and heat loss, and smoking nicotine constricts blood vessels, reducing blood flow to extremities.
Let's talk frostbite first. That's actual tissue freezing.
Yes, frostbite is true tissue freezing. Ice crystals form inside the cells and in the spaces between them, causing direct cell damage and triggering inflammation and edema. It most commonly affects the parts furthest from the core. Hands, feet, ears, nose, cheeks.
And there are different degrees.
Yes, superficial and deep. Superficial frostbite affects the skin and subcutaneous tissues. The skin looks waxy, maybe pale or bluish, feels hard or crunchy to the touch, and the person might feel tingling, numbness, or burning.
How do you treat superficial frostbite?
Handle the area very gently. Absolutely no squeezing, massaging, or rubbing, as that can cause more damage. The key is rewarming. Immerse the affected part in circulating warm water. The temperature needs to be carefully controlled, usually around 99 to 102 degrees Fahrenheit, or 37.2 to 38.9 Celsius. Never use hot water or dry heat like a heating pad. Blisters often form after rewarming. These may need careful debridement and sterile dressings. Rewarming is extremely painful, so provide adequate analgesia and give tetanus prophylaxis.
Okay, and deep frostbite.
Deep frostbite is much more severe. It involves muscle, bone, and tendons. The skin initially looks white, feels hard like wood, and is completely insensitive to touch. As it thaws or progresses, it can become mottled, eventually leading to tissue death or gangrene. The images in the textbook showing severe blistering and eventual necrosis are quite striking. Rewarming is still the primary treatment, using the same controlled warm water immersion method. Elevate the extremity after rewarming to reduce edema. For pain medication, often opioids and NSAIDs are crucial because the pain is intense. Unfortunately, in severe, untreated, or deeply frozen cases, amputation might eventually be necessary after the extent of viable tissue is determined.
That's serious. Now, systemic cold injury. Hypothermia.
Hypothermia is defined as a core body temperature below 95 degrees Fahrenheit or 35 degrees Celsius. It occurs when the body loses heat faster than it can generate it.
What happens physiologically?
Initially, the body tries to compensate. Peripheral blood vessels constrict to shunt blood to the core, and shivering begins to generate heat. However, shivering uses up energy stores and eventually stops, usually when the core temp drops below about 86 degrees or 30 degrees Celsius. As the core temp falls further, metabolic rate slows dramatically. The heart muscle becomes very irritable and prone to potentially lethal dysrhythmias, especially atrial and ventricular fibrillation. The blood becomes more viscous or thicker, increasing the risk for blood clots, stroke, heart attack, and kidney failure. Breathing slows, consciousness decreases.
How does it present? It depends on severity.
Yes, the signs vary. In mild hypothermia, 93-95 degrees F or 34-35 degrees C, the person might just be shivering, lethargic, maybe a bit confused, clumsy. In moderate hypothermia, 86-93 degrees F or 30-34 degrees C, shivering often stops. They become rigid, heart rate and breathing slow way down. Blood pressure might be hard to get without a Doppler. They'll be very confused or unresponsive. In severe hypothermia, below 86 degrees R or 30 degrees C, the person can appear dead. Reflexes are absent, pupils might be fixed and dilated, heart rate can be profoundly slow, or they might be in cardiac arrest like VFib or a systole.
So how do you manage hypothermia?
First, handle the patient gently. Rough movement can trigger ventricular fibrillation because the heart is so irritable. Manage the ABCs. Then, rewarming. For mild hypothermia, passive rewarming, removing wet clothes, applying warm blankets in a warm environment might be enough.
And for moderate to severe?
For moderate to severe hypothermia, you need active rewarming, and crucially, active internal or core rewarming. This means using warmed 5E fluids, heated and humidified oxygen, maybe warm peritoneal lavage, washing out the abdominal cavity with warm fluids, or even extracorporeal rewarming like cardiopulmonary bypass in extreme cases.
Why warm the core first?
This is critical. You must warm the central trunk, the core, before the extremities. If you warm the limbs first, cold, acidic blood containing metabolic waste products from the periphery will suddenly return to the central circulation. This can cause a rapid drop in core temperature, severe low blood pressure, rewarming shock, and trigger those lethal cardiac dysrhythmias. Warm the core first.
That's a vital point. When do you stop active rewarming?
Generally, you stop active internal rewarming once the core temperature reaches about 90 to 95 degrees Fahrenheit, 32.2 to 35 degrees C, to avoid overheating.
Okay. And discharge advice?
Focuses on prevention. Dressing in layers, wearing a hat, a lot of heat is lost through the head, carrying high-carbohydrate foods for energy when out in the cold, having a survival plan if going into extreme environments, avoiding alcohol in the cold.
Makes sense. Let's talk about submersion injuries or drowning. That's another harrowing one. What's happening physiologically?
Drowning is fundamentally a process of respiratory impairment from being submerged or immersed in liquid. The primary problem is hypoxia, lack of oxygen. Interestingly, most victims don't actually aspirate large amounts of liquid initially because of laryngospasm, the vocal cords spasm shut.
So they suffocate even without water in the lungs?
Often, yes, initially. However, if the spasm eventually relaxes or they gasp underwater, aspiration can occur. This leads to pulmonary edema, fluid in the alveoli, surfactant damage, surfactant keeps alveoli open, and potentially acute respiratory distress syndrome, or ARDS.
Does it matter if it's fresh water or salt water?
There are slight physiological differences, though the end result, severe hypoxemia, is the same. Hypotonic freshwater, if aspirated, can be rapidly absorbed from the alveoli into the bloodstream, potentially causing hemodilution and breakdown of surfactant. Hypertonic saltwater, being saltier than body fluids, actually draws fluid from the bloodstream into the alveoli, worsening pulmonary edema. But ultimately, both scenarios severely impair gas exchange, leading to low oxygen levels, brain injury from lack of oxygen, and cerebral edema.
Who's most at risk?
Common risk factors include inability to swim, using alcohol or drugs around water, exercising poor judgment, like swimming alone or during storms, trauma occurring in the water, seizures, and sometimes hypothermia leading to disorientation.
Intervention.
The absolute priority is correcting hypoxia. This means aggressive airway management, ensuring adequate ventilation and oxygenation, often requiring mechanical ventilation with PEEP, positive end expiratory pressure, to help keep alveoli open. You also need to manage fluid imbalances, support cardiovascular function, and actively rewarm if hypothermia is present, which is common in drowning. Aggressive, prompt resuscitation significantly improves survival chances.
Do they need to be watched even if they seem okay initially?
Yes, absolutely. All victims of submersion injury, even if they seem fine after being pulled from the water, should be observed in a healthcare setting, usually for at least 4 to 8 hours, because they can develop delayed complications like pulmonary edema or ARDS. And prevention teaching is huge. Secure pool fences, wear life jackets on boats, supervise children closely near water, and never mix alcohol or drugs with swimming or boating.
Good advice. Okay, moving on to bites, stings, and toxins. These seem like very specific challenges.
They are. And the injury isn't just the physical puncture, it's often the venom or toxins involved, or the risk of infection.
Let's start with stings, bees, wasps, ants. Hymenoptera.
Right, Hymenoptera stings. Their venom can have various effects: cytotoxic, kills cells; hemolytic, breaks down red blood cells; allergenic, causes allergic reactions; or vasoactive, affects blood vessels. Reactions range from just mild local stinging, swelling, and itching,
Which most of us have experienced.
right, to severe, life-threatening anaphylaxis. That's where you see wheezing, bronchospasm, airways constricting, hives all over, swelling of the throat or tongue, and profound hypotension, dangerously low blood pressure.
What's the first thing to do if someone's stung and the stinger's still in?
There's a safety alert here. Scrape the stinger off sideways using a thin, flat object like a credit card or a dull knife edge. Never use tweezers or pinch the stinger,
Why not?
because pinching the attached venom sac can actually squeeze more venom into the skin. So scrape, don't squeeze. Also, remove any rings or watches immediately if stung on a hand or arm, because swelling can happen quickly.
Good tip. How do you treat reactions?
Mild reactions usually respond to cool compresses, maybe oral antihistamines like Benadryl, and elevation. Severe anaphylactic reactions are emergencies requiring immediate intramuscular or IV antihistamines, subcutaneous epinephrine, like from EpiPen, oxygen, IV fluids, and often corticosteroids to reduce inflammation. Anyone with a known severe allergy should carry an epinephrine auto-injector and know how to use it.
Okay. What about snake bites? Are they common?
There are tens of thousands of snake bites reported annually in the U.S., but thankfully very few are actually fatal. Most venomous bites in the U.S. come from pit vipers. That includes rattlesnakes, copperheads, and cottonmouths, water moccasins. Coral snakes are also venomous, but bite less frequently.
What does pit viper venom do?
It's nasty stuff. It can be hemolytic, neurotoxic, affecting nerves, or vascular toxic, damaging blood vessels. Locally, you'll usually see one or two distinct fang marks, severe pain, swelling that can spread rapidly, discoloration, bruising, and sometimes blistering. Severe envenomation can cause systemic effects like profound edema, rapid heart rate, blurred vision, sometimes a metallic taste in the mouth, and serious problems with blood clotting, leading to bleeding.
How do you manage a snake bite victim?
First aid involves moving the person away from the snake, encouraging rest, removing any constricting clothing or jewelry near the bite, and immobilizing the affected limb below the level of the heart if possible. Basic wound care and tetanus prophylaxis are needed. In the hospital, focus on ABCs. 4 fluids are often needed for hypotension. Close monitoring of the bite site for spreading edema, vital signs, and lab work, especially coagulation studies, is crucial.
What about anti-venom?
Antivenom, sometimes called antivenin, is the specific antidote, but its use depends on the severity of the envenomation and the progression of symptoms. It's usually given in consultation with a regional poison control center or a snake venom expert. It can have side effects itself, so it's not given automatically for every bite.
Okay. Let's talk ticks. They seem small but can cause big problems.
They can. Ticks are vectors. They transmit pathogens when they bite. The main concerns are diseases like Lyme disease and Rocky Mountain spotted fever.
How do you remove a tick safely? The book has a figure on this.
Yes, proper removal is key to preventing disease transmission. You want to use fine-tipped forceps or tweezers. Grasp the tick as close to the skin surface as possible. Pull upward with steady, even pressure. Don't twist or jerk the tick. This can cause the mouthparts to break off and remain in the skin. If this happens, try to remove the mouthparts with tweezers. If you can't, leave it alone and let the skin heal. After removing the tick, thoroughly clean the bite area and your hands with rubbing alcohol or soap and water.
What should you not do?
Do not use folk remedies like painting the tick with nail polish or petroleum jelly or using heat to make the tick detach. These methods aren't effective and might actually stress the tick, causing it to regurgitate its stomach contents, including any potential pathogens into the bite wound, increasing the risk of infection.
Good to know. Tell us quickly about Lyme disease.
Lyme disease is caused by the bacterium Borrelia burgdorferi, transmitted by infected deer ticks. It's the most common tick-borne illness in the U.S. The classic sign, though not always present, is the erythema migrans rash. It often looks like a bullseye, starting at the bite site and expanding over days. Early symptoms are often flu-like: fever, headache, fatigue, muscle, and joint aches. If caught early, it's usually treated effectively with antibiotics like doxycycline, amoxicillin, or cefuroxime. If untreated, it can lead to more serious joint, heart, and neurological problems later on.
And Rocky Mountain spotted fever.
Rocky Mountain spotted fever, RMSF, is caused by rickettsia, transmitted by several types of ticks. Despite its name, it occurs in many parts of the U.S., not just the Rockies. It's less common than Lyme, but potentially much more severe. It's the most lethal tick-borne disease in the U.S.
What are the signs?
RMSF typically starts with sudden onset of fever, chills, severe headache, and muscle pain. A characteristic rash usually appears a few days later, often starting as pink spots on the wrists, forearms, and ankles, and then spreading. It can involve the palms and soles, which is a key feature. Because it can progress rapidly and be fatal, treatment with doxycycline should be started based on clinical suspicion before confirmatory lab tests come back. Early treatment is critical.
Okay. What about bites from bigger animals or humans?
Animal and human bites are quite common ED visits. Dog bites are most frequent, followed by cat bites. The biggest concern with these is infection. Cat bites, though smaller, are often deep puncture wounds and have a high risk of infection, commonly with Pastorella species bacteria.
And human bites?
Human bites also carry a very high risk of infection because the human mouth has a lot of bacteria, including Staphylococcus and Streptococcus species. There's also a risk of transmitting viruses like hepatitis B or C. Bites that occur over joints, especially on the hand, like a fight bite where knuckles hit teeth, are particularly dangerous.
How are these bites managed?
Thorough irrigation washing out the wound with copious amounts of sterile saline is crucial. Debridement, removing any dead tissue, might be necessary. Puncture wounds are often left open to drain rather than being sutured closed immediately to reduce infection risk. Tetanus prophylaxis is given based on vaccination status. Prophylactic antibiotics are usually prescribed for bites considered high risk, like cat bites, deep dog bites, bites on hands or feet, bites over joints, bites in immunocompromised patients, or wounds that are already showing signs of infection.
What about rabies?
Rabies is a concern with animal bites, especially from wild animals like bats, raccoons, skunks, foxes, or unvaccinated domestic animals, particularly if the bite was unprovoked. If rabies exposure is suspected, post-exposure prophylaxis, PEP, is essential. This involves thorough wound cleaning, plus a dose of rabies immune globulin, RE, infiltrated around the wound, and a series of rabies vaccine injections given over several days. Rabies is almost always fatal once symptoms develop, so PET is critical.
Okay, shifting from bites to internal threats, toxicologic emergencies, or acute poisonings.
Right. A poison is really any chemical substance that can harm the body if ingested, inhaled, injected, or absorbed through the skin. Poisonings can be accidental, like a child swallowing cleaning fluid, occupational exposure at work, recreational drug overdose, or intentional suicide attempt.
How bad it is depends on.
Severity depends on the specific poison, the dose or concentration, the route of exposure, and factors related to the patient, like their age and underlying health.
What's the general approach to managing poisoning?
Management priorities are always first, stabilizing the patient, manage the ABCs. Then, the focus shifts to decreasing absorption of the poison, enhancing its elimination from the body, and providing supportive care or specific antidotes if available. And critically, you should always contact the local poison control center immediately. They have expert toxicologists available 24/7 and maintain extensive databases on poisons and treatments. They are an invaluable resource.
How do you decrease absorption?
Methods depend on the poison and how long ago it was ingested. Activated charcoal is commonly used. It binds many poisons in the gut, preventing their absorption. However, it doesn't work for everything, like heavy metals, iron, lithium, alcohol, and isn't used if the airway is unprotected. Gastric lavage or stomach pumping is used much less often now, only in specific situations very soon after ingestion of a potentially lethal dose. Whole bowel irrigation might be used for things like sustained release pills or smuggled drug packets.
Enhancing elimination.
This might involve things like giving IV fluids to promote urine output, sometimes alkalinizing the urine, making it less acidic, to help excrete certain drugs like aspirin. Hemodialysis can filter some poisons directly from the blood. Specific antidotes exist for certain poisons, like naloxone for opioids or N-acetylcysteine for a acetaminophen overdose. Chelation therapy uses agents that bind to heavy metals like lead or iron to help the body excrete them.
What about poisons on the skin or in the eyes? Decontamination.
Decontamination is a huge priority, both to stop ongoing absorption by the patient and to protect healthcare providers. Always wear appropriate personal protective equipment, PPE. For skin and eye exposures, the general rule is copious irrigation with water or normal saline, usually for at least 15-20 minutes.
Any exceptions?
Yes, an important one. For dry chemical powders, like powdered lime or some industrial chemicals, you should brush as much of the powder off the skin and clothing as possible before irrigating with water. Water can react with some dry chemicals and actually worsen the burn or cause a hazardous reaction, like with mustard gas, so brush first, then flush.
Good safety point. The chapter mentions specific examples like acetaminophen and aspirin.
Right. Acetaminophen Tylenol overdose is common and dangerous because it causes severe liver damage. Symptoms progress in phases, starting with nausea, vomiting, then maybe right upper quadrant pain, eventually jaundice and liver failure. Treatment involves activated charcoal if caught early, and the antidote N-acetylcysteine, NAC, which is most effective if started within 8 hours of ingestion.
And aspirin.
Aspirin, salicylate poisoning, can cause rapid breathing, ringing in the ears, tinnitus, fever, confusion, seizures, and a complex acid-based disturbance called metabolic acidosis. Treatment includes activated charcoal, possibly gastric lavage, IV fluids, sodium bicarbonate to alkalinize the urine and enhance excretion, and sometimes hemodialysis in severe cases.
Cyanide is another one mentioned.
Cyanide poisoning is rapidly acting and lethal. It blocks cellular respiration. It's sometimes associated with an almond-like odor, though not everyone can smell it. Symptoms include headache, confusion, shortness of breath, seizures, coma, and cardiovascular collapse. Specific antidotes like hydroxycobalamin or sodium thiosulfate are used intravenously.
And after managing the acute poisoning.
Patient teaching needs to cover how the poisoning occurred to prevent recurrence. If it was an intentional overdose or related to substance use, arranging for a mental health evaluation and referral for treatment is absolutely essential before discharge.
Okay, let's broaden the scope beyond medical and environmental issues. Sadly, the ED often deals with violence.
Unfortunately, yes. EDs themselves can be high-risk environments for workplace violence against staff. Hospitals implement measures like security personnel, metal detectors, panic buttons, and staff training in de-escalation and self-defense. But we also frequently encounter patients who are either victims or sometimes perpetrators of violence outside the hospital.
Including difficult situations like family violence, intimate partner violence, IPV, and human trafficking.
Exactly. These involve patterns of coercive behavior used to gain power and control over another person. Victims of IPV are most often women, but men, children, and older adults can also be victims. Human trafficking involves the use of force, fraud, or coercion for exploitation, often sexual exploitation or forced labor.
Why is the ED important for identifying these victims?
Because ED nurses are often on the front lines, studies suggest a high percentage, maybe over 80%, of trafficking victims interact with the healthcare system at some point while being trafficked. They might present with physical injuries from abuse, chronic pain, infections, malnutrition, substance use issues, or mental health problems like anxiety, depression, or PTSD.
What's the nurse's role?
It requires sensitivity and skill. It involved creating a safe environment, asking screening questions appropriately and privately. For example, do you feel safe at home? Or using specific screening tools. Recognizing potential red flags, like inconsistencies in their story, a controlling partner who won't leave their side, signs of physical restraint. Providing information about resources, making referrals to social services or advocacy groups, meticulously documenting findings and notifying appropriate agencies like Child Protective Services or Adult Protective Services if required by law. Some nurses get specialized training to become sexual assault nurse examiners, or SANEs, who provide expert forensic examination and compassionate care for victims of sexual assault.
That's incredibly important work. On an even larger scale, what about terrorism? How do EDs prepare?
Terrorism involves the intentional use of violence or threats to create fear, often using specific agents. EDs in hospitals have preparedness plans for various types.
Like what kinds of agents?
They fall into categories. Biologic agents are living organisms or toxins like bacteria, anthrax, plague, viruses, smallpox, viral hemorrhagic fevers, or toxins, botulism. These often require specific antibiotics, antivirals, or vaccines for treatment and containment measures like isolation. Chemical agents are poisonous vapors, liquids or solids like nerve gases, sarin, blister agents, mustard gas, or choking agents, chlorine. Treatment involves decontamination and specific antidotes if available. Radiologic nuclear events involve the release of ionizing radiation, which is invisible but harmful. Decontamination is key to limit exposure. Explosive devices are most common and cause multiple types of injuries. Blast injuries from the pressure wave, affecting air-filled organs like lungs, ears, bowels, crush injuries from collapsing structures, and penetrating injuries from shrapnel or projectiles.
You mentioned penetrating injuries. Let's talk about those specifically, like gunshot or stab wounds.
Penetrating trauma occurs when an object pierces the skin and enters underlying tissues or body cavities. The severity depends entirely on what structures are injured along the object's path.
Assessment is key.
Absolutely. The primary survey, ABCs, is always the first step. Head trauma from penetration has a very high mortality rate. Neck trauma is dangerous because of the major blood vessels, airway, and spinal cord packed in that small space. Chest wounds can injure the heart, lungs, or major vessels, potentially causing immediate life threats like tension pneumothorax or massive hemothorax, requiring emergent chest tube insertion or even surgery.
Abdomen.
Abdominal gunshot wounds often require surgical exploration because of the high likelihood of multiple organ injuries. Stab wounds might be managed more conservatively sometimes, but internal bleeding or organ damage is still a major concern. Mortality from abdominal trauma often occurs later, from hemorrhage or infection. Even penetrating trauma to the extremities, while maybe less immediately life-threatening than torso wounds, can cause significant long-term disability if nerves, major blood vessels, or tendons are injured. Careful neurovascular assessment is critical.
Okay, finally, let's zoom out to mass casualty incidents. or MCIs. How is that different from a regular emergency?
That's a really important distinction. An emergency is an event that requires response, but can generally be managed using the routine procedures and resources of the community, like the fire department, EMS, local hospitals. A mass casualty incident, MCI, on the other hand, is an event natural or human-made that overwhelms or threatens to overwhelm the community's available resources.
Mm.
The number of casualties exceeds what the system can handle normally, requiring extraordinary measures and often external assistance. Think large-scale events like major earthquakes, hurricanes, large bombings, or pandemics.
And triage works differently in an MCI.
Yes, very differently than standard ED triage. MCI triage happens rapidly, often at the scene, usually taking less than 15 seconds per patient. The goal is different. It's to do the greatest good for the greatest number of people, which sometimes means diverting limited resources away from those with catastrophic injuries who are unlikely to survive in order to save more people with life-threatening but potentially treatable injuries.
How's it done? Those colored tags.
Exactly. A common system uses colored tags. Green tag, minor injuries, walking wounded, they can wait for treatment. Yellow tag, urgent, non-life-threatening injuries. They need treatment, but it can be delayed somewhat. Red tag, immediate life-threatening injuries requiring intervention right away, like severe bleeding or airway compromise. These are the highest priority for transport and treatment. Black tag, deceased or expected to die. These patients receive palliative care if resources allow, but definitive treatment resources are allocated elsewhere. Black tag, decontamination, if needed, like after a chemical exposure, usually happens at the scene before patients are transported to hospitals to prevent contaminating the hospital itself.
Who else gets involved in these large-scale events?
Many groups coordinate. Community Emergency Response Teams, CERTs, are volunteers trained by FEMA in basic disaster response skills like fire safety, light search and rescue, and disaster medical operations. They support professional responders. Every healthcare professional should know their own hospital's or agency's emergency response plan and participate in disaster drills. Federal agencies like the National Incident Management System, NIMS, provide a framework for response, and organizations like the American Red Cross and FEMA provide critical support and resources.
And dealing with an MCI must take a huge emotional toll on responders.
Immense. Disasters create significant acute and long-term stress for survivors, families, and responders alike. Burnout, PTSD, anxiety, depression are common. Many hospitals and response agencies have critical incident stress management, CSIM, or similar programs. These often involve debriefing sessions or group discussions shortly after a major event, allowing those involved to process their experiences and emotions in a supportive environment. It's a vital component of responder well-being.
Wow. Okay. What an incredible deep dive into the really complex world of emergency and disaster nursing. We've covered so much from those lightning-fast triage decisions and the systematic ABCs
Right, the primary and secondary surveys.
to managing specific things like heat stroke, hypothermia, snake bites, poisonings, and thinking about those huge disaster responses.
And hopefully we've emphasized how crucial it is to connect the why, the pathophysiology, to the what, the assessments and interventions. You don't just do things, you understand why you're doing them.
Yeah, knowing why you need to scrape a stinger or warm the core first in hypothermia or look for subtle signs of compartment syndrome, that understanding is really what makes you an effective nurse in these situations.
It's foundational for safe and competent practice.
Definitely. This field demands such rapid critical thinking, adaptability, and just staying calm under pressure while following that nursing process. Hopefully, you now have a clearer roadmap for what to expect and how to prioritize when things get intense.
So maybe here's a thought to carry forward as you continue your studies. In this unpredictable world of emergency care, knowing what to do is absolutely crucial, yes. But understanding why you're doing it, the physiology, the potential complications, the whole system at play, that's what elevates it. That's what turns performing tasks into the art of saving lives. So how will you cultivate that deeper understanding, that readiness and critical thinking in your own journey?